The next speech will be delivered by our online speaker, the very famous laryngologist Tetsuji Sanuki from Japan. And let me briefly introduce him. He graduated at Ihami University, get his MD and PhD degree. He also went abroad to study with Richard Collet in Washington University School of Medicine. After going back to Japan, he studied with the world-renowned Professor Ishiki. Yeah, everybody knows Professor Ishiki because he promoted the cytoplasty and helped the laryngologists to treat many difficult laryngeal disease in Kyoto Voice Surgery Center. And currently, because of his great achievement in recent years, he has become the director of Nagoya Voice and Sinus Center in Nagoya City, Japan. So I met Sanuki many times in the international conference. I always inspired a lot by his talk and learn a lot from him. So again, let's give Professor Sanuki a big hand to welcome his speech. Please.
Hi everyone. This is Tetsuji Sanuki from Nagoya Voice and Sinus Center, Nagoya City University. So it is a great honor to be able to speak with you at this conference. So I'm going to talk about new treatment for spasmodic dysphonia in Japan, the titanium bridge. Let's dive in. I have divided my presentation into 4 sections. How many of you are familiar with spasmodic dysphonia? So spasmodic dysphonia is thought to be focal dystonia. Although the cause is still unknown, symptoms are characterized by the loss of voice during conversation. Symptoms appear in a task-specific manner. However, it is also characterized by the absence of symptoms during coughing, laughing, or crying. So spasmodic dysphonia has 2 major types. The one is the abductor type, in which the vocal folds overclose during the speech. And the other is abductor type, in which the vocal folds widen involuntarily, causing the voice to become hoarse. The very rare mixed type is a combination of the two. We currently have 2 methods of treatment for ADSD. One treatment is pharmacotherapy, such as botulinum toxin injections. Botulinum toxin injections have been used to treat SD with good temporary result and minimal morbidity. However, injections are usually required once every 3-4 months and can result in initial temporary dysphonia caused by incomplete glottal closure. The result of treatment vary, and you never quite know how long they will last, so patients always have the fear and that they will lose their voice. Second method involves surgical treatment, including recurrent laryngeal nerve denervation and reinnervation, thyroid muscle myectomy, and type 2 thyroplasty. The last of which has been shown to provide permanent relief from voice symptoms. There are various treatments for ADSD. Botox injection, recurrent laryngeal denervation, and thyroid myectomy are intended to reduce spasmodic glottal closure. Sometimes treatment for ADSD do not adequately address the problem of tight glottal closure in the patient. This is largely due to the fact that voice tuning, which is performed during type 2 saliplasty, is not possible. Next, I will explain the new treatment with Titan bridge. Type 2 saliplasty with Titan bridge differs from previous treatments in that this surgery does not involve any surgical intervention into the laryngeal muscle, nerve, or vocal folds. Type 2 saliplasty is intended to prevent the spasmodic tight glottal closure at the terminal stage of phonation, which is a fairly mechanical process, leaving untouched the region or structures directly involved. This
During
video
type 2
outlines the surgical
thyroplasty,
concept.
the thyroid cartilage is incised at the midline under local anesthesia. Both sides of the anterior commissure attached to the vocal cords are separated, after which titanium bridges are inserted and fixed. Voice monitoring is performed to determine the optimal spacing of the incised thyroid cartilage. Patients produce their voice at different spacings until voice symptoms are relieved. Following voice monitoring, the optimal size titanium bridge is attached to the thyroid cartilage. By performing voice monitoring together with the patient during surgery, strangulation and breathiness are often eliminated, and patients are relieved of symptoms following the surgery. Titanium bridges are fixed with nylon thread. As a result of affixing the titanium bridges, excessive glottal tightness is permanently prevented, allowing for normal vibration of the vocal cords even when experiencing spasms.
What is a titanium bridge? Before developing the Titan bridge, we evaluated 90 ADAC patients who underwent type 2 saliplasty between 1997 and 2005. Of these 90 patients, 5.6% required revision surgery. Why are titanium bridges important? Before the development of titanium bridges, silicone shims or titanium mini plates were used for fixation. We found some trouble with these fixation materials. The upper silicone shim was found anteriorly displayed on one side. The titanium mini plate caused cracking of the thyroid cartilage. So since silicone shims and the titanium mini plate were not expected to provide good long-term results, Professor Ishiki came up with the idea of developing a medical device that is tailored to the shape of the thyroid cartilage. After some commercialization, he developed a new Titan bridges, the advantage of which are it is biocompatible. The special receptor holds the cartilage gently but firmly. Finally, the pressure created by the liquid closing the force is displaced over the wide area of the curved portion of the receptor. This slide shows the development timeline for the titanium bridge. The titanium bridge was approved as a medical device in 2017 in Japan. In addition, the surgical technique became available for insurance reimbursement under the Japanese public health care system in 2018. Here is the commercial version of the Titan bridge currently available. There are 7 wide sizes, 3 thickness sizes, and 2 winged wide sizes, for a total of 28 sizes. Next, I will explain the treatment effect of type 2 cytoplasty with titanium bridges. Here is a case involving a 31-year-old female patient with ADSD.
の中か
Very
らうさぎが
strangulated
ぴょこん
voice
と出てきました。
and
2、
so
3、
you can hear that very
6、
difficulty voice.
8、9、10。
So after surgery, she experienced
藪の中から
completely
うさぎがぴょこ
calm
んと出てきました。
a strangulated voice like this,
4、5、6、7、8、9、
very
10。
smooth. Next, here is the case involving a 26-year-old male patient,
おはようございます。
very strangulated.
ありがとうございました。藪の中からウサギがぴょこんと出てきました。1、2、3、4、5、6、7、8、9、10。
Then, after surgery, he also experienced complete relief from a strangulated voice
藪の中からウサギがぴょこんと出
like
てきま
this.
した。1、2、3、4、5、6、7、8、9、10。
The next case is a 70-year-old female ADHD patient. So she had a strangulated and tremulous voice before surgery.
1、2、3、4、5、6、7、8、9、10。
So, however, she was relieved of her voice symptom procedure.
4、5、6、7、8、9、10。
So, I previously reported the outcome of type 2 cytoplasty with titanium bridge using the patient questionnaire and perception analysis. Patient rated their voice as excellent, good, fair, or poor. 69% of patients responded excellent and 22% responded good. The surgery was found to be 91% effective for resolving glottal tightness and strangulated voice with phonation difficulties. So I evaluate the effectiveness of surgery by employing the perception analysis using the VHI-10. 47 ADHD patients underwent type 2 cytoplasty with titanium bridge in this study. The average follow-up interval was 41.3 months. The mean postoperative VHI-10 score improved significantly from 26.8 to 9.4. Postoperative VHI-10 scores after the first month showed almost no variation when compared with scores from 3 years after the surgery. Recently, I reported the long-term result of type 2 cytoplasty with titanium bridge versus Botox injections. In this study, of the 73 patients, 52 patients were treated with an initial Botox injection. 11 of the 52 patients subsequently underwent type 2 cytoplasty approximately 6 months or later after their last Botox injection. The main reasons patients switched or discontinued injections was the initial hoarseness. A total of 32 patients underwent type 2 cytoplasty. This slide shows VHI-10 scores for first Botox injections. The pre-injection VHI-10 mean score was 27.3. Following injections, the score significantly improved to 21 at 2 weeks, 18.6 at 4 weeks, and 19.4 at 8 weeks. There were no significant differences between the pre-injection scores and 12-week scores. There were no significant differences in other period comparisons. This slide shows the result of type 2 thyroplasty. The pre-treatment VHI-10 mean score was 27.2. Following clinical scheduled follow-ups, scores significantly improved to 13.6 at 4 weeks, 12.2 at 12 weeks, 10.2 at 26 weeks, and 9.9 at 52 weeks. A comparison of VHI-10 score at 4 weeks with the score at 26 weeks and 52 weeks showed a significant decrease. This slide shows the comparison of the two treatments. When the two treatments were compared with respect to the matching time of follow-ups, there was no significant difference between the pre-treatment score and the score at 4 weeks after the treatment. However, there was significant difference at the 12 weeks. Summary of surgical effects. Botox is a gold standard, but type 2 thyroplasty has significant advantages. Type 2 thyroplasty with titanium bridges result in clinically meaningful, significant, and lasting improvement in ADHD patient quality of life. Finally, I will talk about how to perform type 2 thyroplasty with titanium bridge. Here is an example of surgical procedure. The patient was a 21 years old female. She had a strangulated voice before surgery. 母の日にハンバーガーを食べた。Briefly, お願いします。A next incision about 3 cm in length was made. The salad cartilage was inside the midline, leaving the line of tissue intact. おはようございます。When the inside cartilage is 母の日にハンバーガーを食べた。母の日にハンバーガーを食べた。ありがとうございました。失礼いたします。ありがとうございました。失礼いたします。To maintain the separation, titanium bridges were placed below and above the regulator condition. よろしくお願いいたします。大きな声出る？大きな声は出ます。つまりは？つまりはないと思います。Key points for successful surgery. First is careful surgical manipulation and voice monitoring during surgery. Second is stable maintenance of the gap at the inside the thyroid cartilage with titanium bridges. Why is the surgical technique important? In 2004, Chan reported long-term result of type 2 thyroplasty. This manuscript shows that only about 30% of the patients had moderate to good improvement in their symptom severity and vocal effort 1 year after surgery. The experienced surgical failure largely because the surgery was performed under general anesthesia, precluding any opportunity for voice monitoring during surgery. Furthermore, an oscillator saw rather than the scalpel was used to incise the thyroid cartilage, and in that time titanium bridges were not used to maintain correct separation of the cartilage. To ensure proper surgical techniques are maintained, it is important to join our surgical training course. The contents include lectures, dissection, and live surgery. We hold the course regularly in Japan. Type 2 chiroplasty with Titan bridge will be available outside Japan. Its results in clinically meaningful, significant, and lasting improvement in patient quality of life. Surgical training and the Titan bridge are necessary for successful surgery. So thank you for your attention. Here is my contact information. I'm happy to answer any question you may have.
Thank you, Professor Sanuki, for your wonderful talk. Your talk also remind me of the great Professor Ishiki. Thank you. And is there any comment or question from? Yeah, Peter from Hong Kong.
Thank you, Professor Sanuki, for your wonderful presentation. I have two questions. So it's not uncommon to see patients with spasmodic dysphonia with coexisting vocal tremor, and literature report up to 1/3 of cases with coexisting conditions. So I wonder if you also operate on those patients with significant vocal tremor involving all pharyngeal and laryngeal muscles. And my second question is, when you titrate the size of your titanium plate, what are the parameters you look at or listen to when you titrate the size? Thank you.
Thank you. Great question. I presented in this the lecture with the spasmodic dysphonia with voice tremor. So that spasmodic dysphonia patient, at least I think that 30% of the patient have that tremor. So this surgery indication for only for adductor spasmodic dysphonia, so strangulated voice, not for tremor. So it's not adequate indication for the tremor, only for the strangulated voice. So second question, you asked that how to decide the size of the Titan bridge. So it's for that only for the listening. So you can hear about the to breathy voice or strangulated voice. So it's very important. So this surgery need that under local anesthesia. So it's very important is we need the voice monitoring. It's kind of voice tuning surgery. This surgery is so laryngoplasty is based on the voice tuning. So especially the type 2 chiroplasty need the voice tuning. So always checking that their voice, and then we do have the several special device for voice tuning, Titan sizer or splitter. So not only for the mosquito pen. So I think that two very important question. Thank you.
Any more question? Amanda Hu, please, from Canada.
Dr. Sanuki, thank you very much for your excellent presentation. The titanium bridges are not Health Canada approved and not available in Canada. As an alternative, what else can surgeons use besides the titanium bridges?
I think that before the Titan bridge developed, we use a selective thin or titanium mini plate. So I think that to a few patients acceptable this device, and then unfortunately next year we plan to launch in Europe. So after that, with the US to follow. So in the advance, I think that you can wait the 2 more years so you can get the Titan bridge. Thank you.
That's good news to all of us. And thank you. I think I admire your treatment because your treatment have the 3 major advantages. The first is adjustability, right? You can real time tune the patient's voice and listen to the feedback. And the second is the minimally injury. You do not injure any nerve or any thyroid muscle, so there are probably less complication. And the third is the irreversibility. So if you have you ever meet any patient with complications, or they are not satisfied with their voice, and you need to remove the titanium plate? Is that reversible? And if you, I see your presentation, you do 2 adjuvant Botox injection to your 2 patients, right? So did you consider do a revision surgery and change the size of the titanium plate? Or what's your opinion about this irreversibility or reversibility issue? Thank you.
Thank you. Great question. So I showed that my result about 91% of satisfied, but to less than 10% is unsatisfied. So these patients needed to extra Botox or myectomy or to revision surgery. So or type 2 cerebroplasty revision rate is less than 4% in Japan. So, and in reversible, some patients needed to after the surgery feel that the little bit of breathy voice. So we changed the size of the smaller size, and then so some patient is adequate to affect the after the surgery. So we combine type 2 cerebroplasty with myectomy and the Botox patients. Some patients, or few patients needed extra surgery or extra treatment, these patients. So thank you.
Thank you very much again. And because the time is up, so I need to close this session. And thank you. And I'm looking forward to see you next month in Seoul, right? In the Eastern Asia Conference of Funnel Surgery. Thank you. I can ask you more questions at there. Thank you.
Thank
and
you very much.
thank you. See you next time.
Everyone and everyone.
Yeah.
See you next time. Bye-bye.
To the next speech.